Well, good afternoon or good morning, everybody, and welcome to today's webcast on improving patient experience in large healthcare organizations. My name is Dale Schaller, and I will be moderating our session today, presented by the Agency for Healthcare Research and Quality's CAPS User Network. Next slide, please. Today's webcast is the third and the final in a three-part series we've been doing on strategies and methods for using CAPS surveys to improve patient experience. Our focus today is on improvement strategies in large healthcare organizations related to both inpatient and ambulatory care. We'll be starting with a brief overview of AHRQ's CAPS program, and then follow that with a very quick summary of what research has shown to be the foundational elements of patient experience improvement. And then we'll feature two case studies. The first will be on improving patient experience with communication about medications in Kaiser Permanente system hospitals. And then that will be followed by a case study on improving patient experience with ambulatory care in the UCLA Health System's medical practices. And we will conclude with a few references to CAPS resources for improvement, leaving as much time as we can possibly take to field your questions over the next hour. Next slide, please. Before we get into the meat of the webcast, we'll just review a few of the standard housekeeping details. So if you're having any difficulty hearing audio from your computer speakers, you can always just change the audio selection as shown here so that WebEx calls you back and connects you through your phone. If your computer freezes up during the presentations, you can try logging out and logging back in just to refresh the page. And if you need any help at any time during the webcast, you can use the Q&A feature that I'm going to show you on the next slide. So this is the Q&A box, which should show up on your browser at the the bottom right-hand side of your screen. And just be sure that the drop-down option displays all panelists so that when you ask a question, our whole team can see it. And when you do, we encourage you to share your name and your organization or your role so we know kind of who you are and where you're coming from. Today's session is being recorded, and a replay of today's webcast and the slides will be made available on the CAPS site, along with the previous two webcasts, a part of this series, and also many more. And we'll give you the URL information for that site at the end of today's webcast. Next slide. So I'd like to welcome now and introduce our speakers for today's webcast. We'll begin with introductory comments from Karen Ginsberg, who directs the Agency for Healthcare Research and Quality's CAPS program, as well as the Surveys on Patient Safety Culture, or SOPS program. Karen will be followed by our two case study presenters. First, Stephanie Fishkind, who is a principal consultant at Kaiser Permanente, and then Sam Sklutsky, who is the Chief Medical Officer with the UCLA Faculty Practice Group and Medical Group, and who is also a professor of medicine at the UCLA Medical School. And again, I'm Dale Schaller. I've been a longtime member of the CAPS Consortium, and I will be serving as your moderator. So without any further ado, I'll turn it over to you, Karen.
Dale, hello everyone. Thank you for joining today's webcast. As Dale mentioned, this is the third in a series of three webcasts that the CAPS program is presenting to you on improving patient experience using CAPS survey data. If you've missed the other presentations and you're interested in listening to them, the first is up on our website. The second should be up next week or the week after. You can listen to it then. And this one, should you know of anybody who wasn't able to attend today's event, will be able to find it on our website in about a month. So we hope you'll have a chance to listen if you haven't heard before. Michelle, can you go to the next slide, please? Oh, so we always have new users attending all of our webcasts, and welcome to the new users as well as to the to attendees who have been with us before. But for the benefit of new users, primarily, I'd like to just talk a little bit about the Agency for Healthcare Research and Quality and the CAPS program, so that you have a context for the work that we're presenting today. So I'll start talking about the Agency for Healthcare Research and Quality. We're a science-based agency of the Department of Health and Human Services, and what we do is invest in research and evidence that makes healthcare safer, improves the quality of healthcare. We create tools for healthcare professionals to use to improve care for their patients, and we generate measures and data and that can be used to track the performance of the U.S. healthcare system and evaluate its progress, data that's used by policymakers and researchers and healthcare providers. And one of the agency priorities is to make sure that the science that we do gets to you, our users, so we push our science to implementation. Can I have the next slide, please? The CAPS stands for the Consumer Assessment of Healthcare Providers and Systems, and this is a program to advance the understanding and the measurement and improvement of patients' experiences with their healthcare. We've been around for 26 years, and if you've been with us or you spend any time with us, you'll have heard about the CAPS Consortium, and this is the group that is responsible for the technical quality and the oversight of the CAPS program. And the consortium consists of the AHRQ staff, our funded cooperative agreements, the Yale University School of Public Health, the RAND Corporation, and our contractor, Westat. Next slide, please. So we have an active research agenda. It focuses on understanding patient experience, how to measure it, and how to improve quality with CAPS data. And this is all in addition to the work that we're most known for, which is developing surveys on patient experience of care. And we also conduct research, and we have for a long time, on the best methods to implement surveys. And that's just a part of the research that we do to develop a CAPS survey. And historically, we hadn't made this research available as an end product to you, our users, but it's becoming more and more important that you all understand about the work that we've done on best methods to implement surveys. So we have a page on the website which explains some of our findings of this research and talks about the different modes of administration and their use and effectiveness. The next slide, please. So let me talk a little bit about the CAPS surveys. They are considered the gold standard for patient experience measurement. And when we talk about patient experience measurement, I want to just tell you what patient experience is. Patient experience is what happens to the patient. What did they actually experience? Did something happen? How often did something happen? And it's patient experience is actionable and it's objective. It's often confused with patient satisfaction, but that's an entirely different animal. Patient satisfaction is based on patients' feelings, which are reflected in their expectations of what they for a care encounter. So they're very different kinds of metrics. The CAPS program captures the patient voice, and we do that in different parts of the survey development process. We measure patient experience of care in different settings. We use a standardized methodology and research findings for all that we do. And the CAPS surveys are trademarked, and the trademark is held by AHRQ, and all surveys have to adhere to the CAPS design principles and standards in order to earn the use of the trademark. And that process is overseen by the CAPS Consortium, which I just told you about. So I'm going to turn this back to Dale, who's going to talk a little bit about patient experience improvement and what we've learned over the past couple of decades. Dale?
Great. Hey, thank you, Karen. And I'm going to just do what I've done in the past two webcasts before we dive into our case studies and just briefly set the stage by highlighting a fundamental conclusion that was reached by a team of CAPS researchers almost 2 decades ago, which was based on an evaluation of a quality improvement collaborative with a set of medical groups in Minnesota that was convened over a period of about 18 months between 2003 and 2004. And the conclusion was, as is shown on your screen, that small measurable improvements in patient experience may be achieved over short projects. Sustaining more substantial change is likely to require organizational strategies, engaged leadership, cultural changes, regular measurement and performance feedback, and experience of interpreting and using survey data. And this fundamental observation that you can make small improvements in some specific aspects of patient experience, but that to sustain larger improvements over time, you really need to address organizational changes in leadership and culture and in systematic measurement and feedback. That's been borne out over and over again over the last 20 years in the research literature that's looked at case studies and expert reviews of high-performing healthcare organizations. Next slide. And the research has consistently identified about a half a dozen foundational elements or key factors that are critical for a healthcare organization to achieve in order to sustain high levels of patient-centered care over time. And the first and maybe most important of these is leadership and governance commitment at the CEO and board level to a strategic vision that embraces the importance of patient-centered care. True partnerships with patients and families at multiple levels is also critical. That includes policy and planning, the co-design and co-production of improvement and redesign efforts, and of course, partnerships at the individual care delivery level. The third factor is having a strong focus on the workforce that embraces the importance of recruiting and training and recognizing and rewarding all employees, recognizing that positive patient experience is directly tied to the positive experience of the clinicians and staff who serve them. And next is the systematic measurement and feedback that uses a combination of quantitative as well as qualitative methods to assess patient experience and provide routine metrics for monitoring and improving performance. And finally, having a supportive technology and infrastructure, things such as patient portals, telehealth services, particularly these days, decision support tools, and then a built environment that's not focused on amenities, but structural elements such as wayfinding, noise reduction, access to light, and natural elements that help to create a healing environment. Not all these elements are going to be covered in each of the case studies that are presented today, but we wanted to highlight them again as context for the studies that will be presented. And with that, I'm really pleased to turn it over to Stephanie Fishkin now for our first case study presentation. Stephanie?
Dale. Hello, everyone. Today, I will be sharing how Kaiser Permanente is using the hospital CAP survey as a key tool for patient experience improvement. Next slide, please. But first, before we dive into this improvement work, let me briefly provide an overview of Kaiser Permanente. For 75 years, Kaiser Permanente's mission has been to provide high-quality, affordable healthcare services and improve the health of our members and the communities that we serve. Kaiser Permanente has over 12 million members of regional health plans across the United States. 39 acute care hospitals all field the HCAHPS hospital CAP survey. 72 hospital outpatient and ambulatory surgery centers fielding OAS CAPS. 30 home health agencies fielding home health CAPS. 26 hospice branch agencies all fielding hospice CAPS. And 1 in-center hemodialysis facility fielding ICH CAPS. In addition, Maui Health System partners with Kaiser Permanente for all community members regardless of health coverage. This system consists of 1 acute care and 2 critical access hospitals, all fielding HCAHPS and OAS CAPS. So the CAPS work that I have been involved in for over a decade now with Kaiser touches all of these facilities. Next slide, please. Kaiser Permanente is an integrated healthcare system that includes care and coverage. Our integrated model aligns hospitals, physicians, and the health plans to drive coordination of care across all settings and providers. Kaiser Foundation Hospitals are a nonprofit public benefit corporation that owns and operates 39 hospitals in the Western United States. The Kaiser Foundation Health Plans are nonprofit public benefit corporations that contract with Kaiser Foundation hospitals and medical groups to provide services. Finally, the Permanente medical groups are regional professional corporations which contract exclusively with the Kaiser Foundation health plans to provide or arrange medical services for members and patients. In addition, Kaiser Permanente recently opened an accredited medical school and is waiving all tuition and fees for classes entering 20 through 24. Next slide, please. So now that you have a bit of background about the Kaiser Permanente system, let's dive into the inpatient case study. Next slide, please. One of the publicly reported HCAHPS composites is the medication communication composite. This composite assesses how well a hospital communicated with the patient about any new medicines they received during their hospital stay. If patients were given medicine that they had not taken before, the survey asks how often staff told the patient what the medicine was for and what side effects it might have. Medication communication was the first successful HCAHPS practice to be packaged into a national playbook. These playbooks are an important component to Kaiser Permanente's high reliability in healthcare journey, the goal of which is to provide a consistent approach to patient experience that can be implemented across all facilities and regions. These patient experience playbooks are based on evidence-based practices and approaches using common standards and implementation guidelines and tools to promote consistency and alignment across the enterprise. As part of this high reliability journey, we are moving from our hospitals having relative autonomy for developing their own service standards to moving towards a more single unified service performance improvement strategy with cross-regional buy-in. As a result, the movement towards a standard can be slow, but by engaging key stakeholders early in the process, not only local leadership, but from our labor partners and our members, it allows our key stakeholders to have a voice in this process. Next slide, please. This slide summarizes the general steps taken to create and standardize our HCAHPS playbooks. Gap analyses identified the medication communication composite as an area of great opportunity for improvement. An interdisciplinary multi-site team was then convened to learn about the best practices, both internally and in published research and industry white papers. These learnings formed the basis of our national playbook. Our Baldwin Park Hospital in Southern California was demonstrating high performance at the time that this work began. We worked with Baldwin Park to plan a visit with an interregional team of collaborators to visit and study the practice and the factors leading to the high level of performance. We call this a bright spot session, and the goal is to partner with the leaders, frontline staff, and patients to surface key insights about their success. Our national medication playbook provides our hospitals with a standard workflow, including set, transparent roles and responsibilities from executive sponsorship to frontline staff nurses to the inpatient pharmacist, an implementation timeline with high-level steps that facilities are expected to follow, including identifying key dates and obtaining local sponsorship endorsement for implementation. Implementation resources, including training tools, member-facing medication information flyers, and standard discharge room signs. After a successful playbook piloting, this work has been spreading enterprise-wide since 2018. As local and regional leaders engage in the learning and adoption process, these playbooks and tools continue to be refined. Our current improvement processes build on prior work to sustain and continue to improve performance in this domain. 3 practice workflows specific to medication communication were identified where patients would receive information about their medicines. These are outlined on the next 3 slides. Next slide, please. The first practice workflow sets the stage. The key enablers listed at the bottom of the slide are actions that are intended to provide a safe space for patients to ask questions. When the patients arrive on the unit, they see the AHRQ document posted on the wall. Those 3 questions that patients are encouraged to ask, and those are, what is the name of this medication? Why do I need it? And what are the possible side effects of this medication? When the nurse arrives, the patient and nurse review the contents of the medication folder containing educational materials, and the nurse reviews the concept and purpose of both the AHRQ poster and the medication folder. Next slide, please. The second workflow reiterates these prior learnings. The AHRQ is reinforced by the nurses during their shift. Every time the medicine is given to the patient, The nurses conduct a teach-back to validate that the patient understands the purpose of their medicines and the possible side effects. During the check-back or rounding period, the nurse checks back with the patient on pain control and medication side effects. And this information is updated with the next nurse during the nurse handoff for the next shift. Next slide, please. Finally, the last practice workflow comes at discharge. The discharge nurse posts a do not disturb sign outside the door. That way, the nurse and the patient can review the medications and discharge plans uninterrupted, using that teach back to assure understanding. And the patient takes home the medication education sheet. Next slide, please. The trend chart on the left shows our ongoing improvement journey for the medication communication composite. As you can see, this is still a work in progress. Program-wide, we are in the 60th percentile nationally for this measure, although our highest performing hospitals are in the top quartile. The table on the right shows our HCAHPS medication communication composite star performance for every Care Compare hospital refresh that happens in October. The October refresh is the one that provides the scores for the prior calendar year. So the first column shows our scores for calendar year 2015, and the column on the right shows our scores for 2019. Comparing those two, you can see that we went from 2 Kaiser Foundation hospitals scoring 4 stars on this composite to 10 scoring 4 stars and 1 scoring 5 stars on this composite. Communication about medicines has been a focus area for several years, and over the past year, our regional teams continue to spread the HCAHPS medication communication playbook. Prior to COVID, it was our most improved HCAHPS composite, and we have some emerging improvement in our Northwest market this year. Next slide. So thank you very much. If you have any questions after the Q&A today, you are welcome to email me at Stephanie, S-T-E-P-H-A-N-I-E, .a.fishkin, F-I-S-H-K-I-N, at kp.org. Thank you.
Hey, Stephanie, thank you very much for that very, very helpful overview of communication about medications at Kaiser. We do have an opportunity, as I outlined at the beginning of the webcast, for all of you to send in questions through the Q&A box at the lower right-hand corner of your screen. So please continue to do that. And while you do that, we'll turn it over now to Sam Skutsky for an overview of ambulatory care improvement strategies at UCLA Health. Sam?
Thank you, Dale. Can you hear me?
Yep.
Okay, great. Well, thank you very much for allowing me to present our work here at this webinar. Next slide. Just want to provide, next slide. We don't need this one. Thank you. Want to provide a few facts about UCLA as it relates to ambulatory care and our use of the clinician group CAHPS survey, which is the focus of this presentation. UCLA Health is an academic integrated health system in Southern California. We have now more than 190 ambulatory practice sites. These are individual practices. It includes primary care and specialties, and there are over 2,000 physicians involved. Next slide. This gives you a little bit of the scope of our use of the CAHPS survey. We're currently using a standard CG CAHPS 3.0. We used both the child and the adult version. We have added 3 verbatim prompts that relate to staff, the provider, and general areas for improvement. We're getting about 40,000 surveys per year. We have a sampling method, and about 45,000 verbatim comments. As you'll see, as listed, about 95% of the surveys are the adult, a much smaller number are child. We survey all providers, primary care and all specialists. About 900 doctors get individual reports. We've been doing this for a very long time. We started with the very early versions of CG CAHPS in 2006. And is probably of interest that since last April, we've included all visit types in the survey: in office or in person, televideo, and telephone. We have a standard analysis approach, which includes case mix adjustment, and we have layered reporting, both for the individual physician, for site managers, for clinical department chairs, and the whole practice. Next slide. Our CG CAP survey is administered in a multimodal manner, continuous and year-round sampling. So this is not periodic sampling. We collect survey data every day. And it starts with an ambulatory visit, which is in the upper left. And the first thing that happens is that they get an email invitation to complete the survey by web. And after a specified period of time, if that doesn't happen, then a live agent calls the patient and inquires whether or not they would be willing to do a survey. And then the patient is transferred to an interactive system to do the survey by telephone. There's a fairly robust reporting schema that includes an online web portal for what we might call our expert users. The individual providers get a summary report approximately twice a year. There's a leadership distribution and also a special distribution to clinical managers. As you can see in the orange bar, about 75% of the responses come over the telephone through the automated system, about 20% by web, and 5% require assistance. Our response rate has been about 30% recently. To enhance response rates, patients are alerted ahead of time that they may be asked to complete a survey, and we have found that to be a best practice. Next slide. Our goal is really a sustainable organizational change. So we've been at this for a long time, and we have multiple interventions. So we have about 5 defined interventions to improve the patient experience listed here. The older ones are on the right, and the newer ones are on the left. The oldest is our CRE Care training, which has to do with standardized behaviors for staff and providers. This is a broad organizational initiative that includes things like connecting with the patient, introducing yourself to the patient, and communicating what you're going to do, among other things. Next is our ambulatory resource team, which is doing direct observations in the practices and includes a scorecard with a particular focus on things that we think affect the CG CAPS office scores. I'll give you more details in a moment. Next is our physician communication workshop, which is led by a skilled facilitator, and this is focusing on techniques to improve doctor-patient communication. On the service recovery side, we have a new initiative where after the visit, the patient gets by phone a text survey where they're basically asked to rate their experience from 1 to 5 on a star rating. And patients that have low ratings, then the office manager calls them for service recovery. And we also have a focused quality improvement project where the CG CAP scores are reviewed with each clinical director and manager individually. And I'll provide some additional information on that. Okay, next slide. So the focused quality improvement work is based upon review and action planning from the CG CAP scores at the practice level. It involves the use of an A3 device, which, as you know, is a structured problem-solving and continuous improvement approach to improvement work. And as this slide briefly outlines, that the objectives of the improvement project are reviewed. The scores at the practice level are reviewed with the managers. And we also identify a top 5 areas or items from the survey that drive patient loyalty. And these top 5 are derived from a particular statistical analysis. On the action planning side, the A3 device is used, and both current situations and root cause are reviewed and plans are made. Action plans are made. Next slide. Our doctor-patient or patient-physician communication workshop is in two parts. The first session really focuses on demonstrating and talking about strategies that create a satisfying visit with the patient, how to use time efficiently, and how to develop mutually agreed upon treatment plans with the patients. They then go and practice those skills and come back. And the second session really has to do with building upon these habits that were taught and having the providers share with the group encounters that they found particularly difficult and not satisfying. And this is led by a skilled clinical psychologist, subject matter expert. And we get very high reviews from the physicians on this course. Next slide. The ambulatory research team is a multidimensional, has a multidimensional focus, but it's particularly focused around staff interactions with patients. And it involves, as listed, the aesthetics, the look and feel of the practice, the check-in process, rooming the patient. There are peer managers and coordinators from other practices that round and make the observations. And the goal is to share best practices throughout the organization. There are recognition and incentives. There are financial incentives tied to performance for the office managers and directors, and staff receive both incentives and formal recognition. Next slide. This gives you some idea of what's involved with staff training. There's a 2 to 4 week standardized training. We incorporate the CI care into all patient interactions. And new hires also have an opportunity to demonstrate various proficiencies in a lot of the tools that they would need to use, such as the EHR and their support for ambulatory nursing and other things in our environment. Next slide. There's another group of staff that have been hired particularly to work with our high-risk and complex patients. So in addition to improving clinical outcomes, these staff are also striving to improve the overall patient experience by coordinating care. And examples of what they're doing has to do with escalating patient concerns, making sure that phone calls are returned, making sure the patients are getting their appointments, authorizations are obtained, test results reviewed. So we do this for our most complex patients because they really need help navigating the healthcare system, as I'm sure you would all agree. Next slide. We've identified some success factors in this work, and this has to do with engagement from the clinical directors and practice managers. There's weekly meetings. There's weekly review of the dashboard and metrics. I'll show you an example of the dashboard in a moment. They hold each other accountable. As I mentioned, there's peer rounding in each other's practices. They're sharing of best practices. And there are some centralized resources that help make it work. There is a patient communication center where for the majority of practices, incoming calls are managed. And there's ambulatory nursing and patient experience as in addition to the employee training. Next slide. This just gives an example of one of the AHRQ scorecards, and there's many dimensions to this and tracking. But as I put on the right-hand side, that there are certain elements that we feel directly affect the CG CAPS office scores. And these have to do with eye contact, introduction, friendly greeting, being polite when approaching the patient or groups, and wayfinding, escorting patients when that is necessary. Next slide. Shifting gears a little bit, I wanted to share with you some data that shows that UCLA Health, the telehealth visits have persisted after the pandemic. What this is showing in the part of the graph, which is in the red box, is that's around during April of 2020. And what it's showing in the blue bars that start pretty tall and then go down to very little, those are the in-office visits. And what this is showing is that starting in mid-March and April, the number of in-person visits declined dramatically. And the orange bars show the growth, the rather dramatic immediate growth of telehealth visits. And over time, and this is in the gray bar, that's the total number of visits. Over time, the total number of visits actually has gone back pretty much the way it was pre-COVID. But you'll see as in the green bar, what you'll see is that the in-person visits have not totally returned to where they were. And there's about maybe 20% that are now telehealth visits. Almost all of these are televideo. There's very few telephone visits, but there are a few. So next slide. So we've had some adaptations due to the COVID-19 pandemic. As I mentioned, both the televideo and the telephone visits have been included in the survey almost from the very beginning of the pandemic. Certain things we had to convert to online courses. The physician communication course was converted to an online Zoom type course, and the art training and e-learnings also had to be converted to online courses. And then we also restructured art a little bit to focus on some of the CDC guidelines for interactions within public settings, including face coverings and screening visitors for symptoms, personal protective equipment being worn when appropriate, and also encouraging patients to complete the check-in process online so they would feel that their interactions with people are minimized when not absolutely necessary. Next slide. So I want to thank you very much for allowing me to make this presentation. My contact information is shown, skutsky@mednet.ucla.edu. That's SSKOOTSKY@mednet.ucla.edu. Thank you very much.
And thank you, Sam, and thank you, Stephanie, and thank you, Karen, for leading us up to this point in the webcast where we will be fielding a number of the questions that have come in through the Q&A box. And I just wanted to start with a question for both of you. I think it's pretty straightforward, but Laurel Jameson Wilson asks if Kaiser Permanente and UCLA self-administer their surveys, or how are your surveys collected in your respective organizations? Stephanie?
Thank you. Yes. So of the surveys that I mentioned, only CMS only allows hospital caps to be self-administered, but we have chosen to have a single vendor enterprise-wide for that survey, and all the other surveys mandated by CMS require the use of a vendor.
Yes,
yes, at UCLA Health, what we've done from the very beginning is you might say we have assisted self-administration of our CG-CAP survey. So we do utilize a vendor who takes care of the mechanics, if you will, of the survey through the email and telephone. And we've worked with them over many years to develop our own customized case mix adjustment. And the format of the reports and the things that we send to leadership and the physicians, really we have designed ourselves, with the vendor, so it's all customized.
Okay, great. Thank you both. So Stephanie, Anna asks a question. First of all, she thanks you for a wonderful presentation, and she would like you to elaborate a little bit on how you addressed communication about medications for patients whose primary language is not English. And I'm assuming that could be a fair portion of your patient population, at least in some of your regions.
Yeah, that's an excellent question. Excuse me. Yes, we looked at what our most frequently non-English speaking languages were, and so the materials by default are available in English, Chinese, and Spanish. In addition, if we have patients who are not familiar in any of those languages, we have interpreter services available for many other languages.
Okay. And one follow-up question to you, Stephanie, just in general. The question comes from Vicky. I'm going to mess up her last name, Bang. I was wondering if you encountered any resistance to the implementation of your improvement strategies for medication communication. And if so, what were they and how did you address them?
So like I mentioned, we tried to engage those stakeholders early in the process, knowing that resistance is part of this, this process. So, we talked not only to the local leaderships, but we had our labor partners and our members engaged in this process. So we had the development of this playbook included representatives from all of the KP markets, and all of that together sort of helped to mitigate that resistance. That being said, the markets we've also seen that the markets have tweaked these playbooks somewhat. They have taken them and tried to make them reflect their culture. For example, our Northern California market has a playbook that they call My Medications Matter. It may be slightly different, but the general components are the same as the enterprise playbook.
Okay, great. Thanks, Stephanie. Sam, Port Montrose has posed a question actually for both of you. Let me start with you, Sam. Noticing that improvement ideas that you mentioned were solicited directly from patients, can you talk a little bit about how those ideas are then handled or processed and then implemented? Sam?
Oh, I'm sorry. Well, actually, I didn't mention that they were directly from focus groups, although we do have that. We're using the responses from the CGCAP survey, unless I misunderstood your question.
Oh, I think that's a good answer. So the ideas that you're working to process and act on are basically, they emerge through the survey analysis, the results that you get.
Yeah, and also we do have the verbatim responses as well, which the managers find equally as revealing as the survey.
Yeah, Stephanie, do you have any comment on that question?
It's pretty much the same. We rely on, using those CAP surveys as the voice of the patient, and we have open-ended, space for open-ended comments, and we try and analyze and look at those comments. From my end, it's on the enterprise level, but we have, local care experience staff who have the ability to review those at the patient level, and we get a lot of feedback from that information.
Mm-hmm. Yeah. So Sam, you mentioned some very interesting findings toward the end of your presentation regarding virtual visits, and there were a couple of questions that came in actually in the registration process regarding how, if you handle patient experience improvement strategies any differently when you're providing care virtually, or can you comment a little bit on sort of best practices for assisting patients in using virtual technology for patient care?
Yes, thank you. I would say one of the best practices that we have unraveled, which others talk about, is the need to have staff make sure that the patients can utilize, the telehealth technology, that they know how to log on, they're not confused about how to communicate. So we actually have staff calling the patients ahead of time to make sure that they don't have any questions. So I would say that's one of the main things actually that has to be implemented, because all of these things require a lot of clinical operations support. So you can't just do televideo, but we have found that having staff contact the patients ahead of time and make sure they understand how to do everything is a key success factor.
Thank you. And again, to you, Stephanie, this is another question that came in through the registration process. Again, sort of in the context of our 2020 pandemic experience. And what impact did COVID have on your patients in terms of returning to a safe hospital environment? And how are you handling this whole process of easing the minds of prospective patients that it is safe to come back into an inpatient setting? Stephanie, are you on mute? Yep, you are.
Sorry. There's a lot of, I'm sorry, I'm not the best person to address this question since my side is more the analytics side. I can tell you that in general, there's been a lot of work enterprise with our National Care Experience partners and locally with our leaders and frontline staff to create an environment where our patients have that feeling of safety upon return.
Yeah, yeah. I have another question that just came in, and it's from Muhammad Afzal Khan, and I'm just reading it for the first time, so bear with me. Thank you for providing an opportunity to learn more about healthcare quality improvement and understanding patient experience and using this important feedback to improve our services. His question is, do we need to educate our patients to understand our system of healthcare improvement and know their rights and capacity of our delivery? I guess this is oriented to the importance of reaching out proactively to patients to educate them about how things generally work for improvement and what their rights and role is in that process. I can direct that to either you, Sam, or Stephanie.
Well, I would say, so we work with our vendor. Our vendor has a campaign where we encourage the patients to respond to the survey. And I think a lot of that, provides for discussion with the patient on how important we feel this feedback is. Mm-hmm. In addition, we have a phrase we use called respect me, know me, and guide me to ensure that the patients are included in many of their decision-making capabilities.
Sam, you mentioned in your presentation that you provide your patients with sort of an advance notice that they may be getting a survey. I understood that to mean that would be above and beyond just sort of sending them an invitation. Is that right? And so how do you do that sort of alert to patients?
Yes, we've done different things over the years, and we also consider that a best practice to help improve response rates, to signal to the patients that their voice is valued. So we've had notices in the offices. They used to be kind of paper, cardboard kind of notices, mm-hmm. But we have electronic displays with notices, so it's incorporated there. And then most of our patients use our patient portal through the electronic health record. So in those systems, the patients get reminders about upcoming appointments. So what we've done is in those appointment reminders, we've included a sentence or two about the survey, and that that we would like them to respond, and that we value their voice in that process.
And you have found that those practices actually do contribute to increasing your response rates.
That is our conclusion. Yes.
Okay. Great. Here's a question from Ephraim Abibi, who thanks again both of you for great presentations, and wondering if you could expand a little bit more on how you share your survey results with clinicians on the front line and helping them sort of translate those results into improvements. I think it's kind of a feedback. How do you engage your frontline clinicians with the survey information?
Yeah, I can describe a little bit about that. So during our onboarding process for new clinicians, there's actually a session about the CGCAP survey, and it describes what it is and why we're using it. It goes in very briefly about how the CAPS development work and how it can tease out different aspects of the patient experience. And then we talk about the survey itself, and we talk about the case mix adjustment and how it's scored. And then we actually show them examples of the kind of reports that they would get. And then, the ongoing process is these are distributed to the physicians, but then the practice leaders are also going over these results with the clinicians as part of their normal kind of peer review. Actually, it's not a formal peer review. I would say their normal review of performance for improvement.
Mm-hmm. Stephanie, do you have any comment on that question? And if not, I can actually move to a sort of an interesting twist on that same concept, which is from Liz Glass, wondering if either of you, and Stephanie, I'll ask you first, have engaged patients directly in the improvement work that you've described, either through sort of, co-design activities or like patient and family advisory councils. Has that entered at all into the work that Kaiser's done through, for example, your HCAPS improvement efforts?
Absolutely. We have an entire program that's dedicated to this perspective of engaging the patient and family councils in this work. The patient partners are involved in many aspects of the care, not only within the hospitals, but in other settings such as home care. And you could even consider, the supplemental questions that we ask on our surveys have been guided by some of this work as well.
Mm-hmm. Sam, how about your experience at UCLA Health? Have you engaged patients directly in the improvement process?
Yeah, we have the patient advisory panels. So I would say that's probably the most systematic way that we're getting information directly from patient representatives, aside from the survey and the verbatims. But we do have the patient advisory panels.
Mm-hmm. So stepping back a little bit to kind of the big picture, I want to kind of toss a question to both of you, which again sort of gets at sort of the overall sustainability, sort of long-term durability of the improvement work that you've done. The question is, what's, if you can, the number one tip or takeaway from your experience so far in your respective systems about how to have a quality improvement project sustainable over time? What would be the one factor, if you can, that helps to assure sustainability?
So this is Stephanie. For us, it's definitely staff engagement. Mm-hmm. Particularly in the specific improvement effort at hand, whether it is more of a broad cultural change or a focus on a specific HCAPS question.
Sam?
Yeah, I would say, in the kind of organization that we have, it kind of starts at the top. So for any sustainable change, because real resources are needed to do the work. So we have to have executive support, stated executive support from the top of the organization down. I would say that's a key success factor. And then the other is actually what Stephanie just mentioned. So then in doing the work, broad engagement, and a lot of that, it's like teaching someone to fish, story. So a lot of that we have found is around teaching people how to do the improvement work in a systematic way, because a lot of times people are interested in improving, but they may not know exactly how to go about that.
Right. Yeah, I think that's very good. And I think both of those answers sort of map to the overview that I tried to do quickly at the top of the webcast, identifying sort of these major sort of foundational elements of a longer term sustainable change, which actually leads me to one maybe final question for both of you. And it actually is a question that came, I think, to me from Jeff Palawoda at QDM, who I think is looking for some sort of quantification. I mean, if we're talking about small measurable improvements versus things that are more substantial, how in terms of, your CAP scores, I'm going to turn this back to both of you real quick and ask, what in your system actually counts for a substantial improvement in scores. And I ask that because we know, CAP scores are pretty stable in general. They're hard to move for all the reasons we've been talking about. But what sort of a degree of movement, sort of in terms of score changes, is it 2 points? Is it 3, 5? What in your organizational perspective sort of accounts or would define as a substantial change? Stephanie?
There's so many ways to think about that, because it's going to depend on where are they starting from.
Right.
Any movement from a low performer is good improvement. Whereas a high performer, it's very, very hard to move up once you're at a certain level of these scores, and just sustaining that change is, in and of itself a good thing.
I agree. Sam?
Yeah, I think those are excellent points. We don't have a formal definition, but from the literature, there is described that a small change, if you will, in quotes, small change in CAPS might be a change of 1.0, and something that's more than 3 would be quote unquote large. So when we look at the faculty practice group as a whole, we often sometimes see a change of 0.5 that will be statistically reliable, so we're over time there's been improvement on many of these metrics, and that's what I look for is if it's gone up by 1.0 over X amount of time, that would be a real change, even though you might consider it on the small side. Certainly anything 3 or 5 or something like that would be a major improvement if you have a large surveys.
That's huge with respect to CAP scores. I agree with your answers, and also would say it not only depends on where you start, but what particular composite or sort of measure composite are you looking at? Because communication can be more difficult, for example, than access sometimes. So a lot of it depends on what particular domain you're working in. We are 1 minute away from our ending time, and I just want to thank you both again, and Karen, you as well, for a wonderful presentation. One of the questions actually asked about, do you have opportunities in other venues to share your experience? And I guess that's a way for me to say that we have a website at the CAP site, which has a lot of resources that include not only the experience of Kaiser and UCLA Health, but other organizations that are documented in a sort of a summary of a research meeting that was held last October. We have a CAPS improvement guide, which reviews guidance for health plans and medical practices on organizational strategies, as well as very specific interventions that can be applied to the major domains of the CAPS health plan and clinician and group surveys. And all of this is available through the next slide, please, our website. And there's another way to keep informed and stay informed on these kinds of resources in future CAPS webcasts, which is to sign up for routine CAPS updates, which you can do on the AHRQ website by clicking on the right-hand corner and choosing email updates associated with CAPS. Next slide. So here is how to get in touch with us on an ongoing basis by email at CAPS1, CAHPS1 at westat, WESTAT.com, by our hotline phone number, 1-800-492-9261, and of course the CAPS website, which is www.ahrq.gov/CAHPS CAPS. So thank you again, everyone, for your participation today, particularly our speakers, Sam, Stephanie, Karen. We look forward to staying in touch with you, and please fill out the feedback evaluation form that it will pop up after the webcast ends. And again, contact us at any time. And again, thank you for joining us. And that's the end of our webcast, and have a wonderful day.